Hi, this is going to be a series of lectures for the newborn care, and this is the first installment. It's only going to run 15 minutes, so we're going to do this document. I want you to pull this document out, preferably hard copy in front of you while I show you on the screen what this entails. And I'm mostly going to emphasize, not so much read it to you. So first, let's go to newborn care. I want you to review newborn assessment that you got this prior at the beginning of this week, and make sure you understand newborn assessment. So let's now talk about the care. From birth through the first 2 hours, always in priority is checking the airway. The birth of the head, we talked about in labor and delivery. We stop at the head at the perineum before the baby comes out, and we use a bulb syringe or a deeper suction called the DeLee. And then we always suction first his oral pharynx, then his nose. We never invert the baby and slap him on his bottom. So all this, the rationale, know your rationales. We want to prevent the aspiration of the meconium, if it's there, or the amniotic fluid. It does prevent inspiration of that fluid. We won't call advanced cardiac life support if we need to, if the baby's Apgars are low, the scores are low, and we'll talk about Apgars in a few minutes. We don't want to vigorously suction because it may do a reflexive bradycardia and put them in laryngeal spasms. We don't want to do that. You'll see, if you see a live birth, they will clamp the baby's cord. And we talked about in labor and delivery, we always keep the baby at the same level as the placenta. They will clamp it closed, and they will check for vein, artery. There should be 3 vessels, and we'll talk about that more a little bit later, but that should be in your assessment portion of your newborn assessment. We usually clamp it close to the umbilical cord, its little abdomen. If they leave it long, from 8 to 10 centimeters, they will, to gain access, venous access, to do an exchange transfusion. So we can use the vein still and the artery still in the umbilical cord for IV access. We don't want to raise the baby. We don't want to lower the baby because it can cause a reverse transfusion, especially if the baby is higher than the mom. So some of his blood might go back to mom, and you don't want to do that. Never strip the cord, might hemolyze the RBCs, might cause hyperbilirubinemia. We want to make sure we encourage attachment, keep them warm. We'll call it skin to skin is a big thing now, and we will promote breastfeeding. We want to decrease heat loss and cold stress. Cold stress is something we talked about in assessment. Always keep his temperature greater than 97.4, and because of the breastfeeding, it will encourage what we call involution. We talked about that in postpartum assessment. That's the contraction of the uterus. Plus, we want to see the mom and baby touching, holding, and caressing. We'll do Apgar scores, which we'll talk about in a few minutes below on this document, which will check the baby's physiological state. If you are in the delivery room, in the OR for C-section, or in the vaginal delivery room, you can put the erythromycin in to decrease ophthalmia neonatorum, and we will take his weight and his length. We'll put ID bands on. We'll talk about that more in clinical orientation, and we'll talk about baby safe, and that will be in clinical orientation. Here's the Apgar score, and it's kind of like the Olympics. I want you to review it, and of course, like anything in lecture, you want to read your required reading, because remember, required reading tells the whole story. So right here, we see the Apgar score, and it's 5 categories with a score from 0 to 2, 1 minute of life at 5 minutes of life. And I show you the score that can be the maximum possible. It's kind of like the Olympics. 10 in the first minute, 10 in the next 5 minutes. And if you look at this, I want you to give yourself some study questions. If you get a baby, they will describe the baby, and I want you to be able to develop Apgar scores yourself. When we do see babies delivered, we typically see most babies have this correct at 2 points. Good cry, active motion, and the reflex irritability is good. If we move him around, he'll cry. The only thing they usually get that point off is usually color because of the acrocyanosis. Remember the blue hands and blue feet? So he might be born at 9 instead of 10. That is the most common. If we go over here on the right side of the page, you're going to see I made a chart from the baby's first day of life all the way to the 14th day of life. So from 2 hours to discharge to 14 days. Whereas this is from birth to the first 2 hours of life. When we talk about weight, we're talking about it is normal, and you want to remember that, for the baby to lose 5 to 10% of its weight loss, its birth weight in the first 2 days of life. So you want to remember that if the baby in the hospital in the first 2 days has lost about 10% or less of its birth weight, that is normal. Remember, week is about normal. It's not abnormal, it's normal variations. All the way until, excuse me, to the first week, which is 10% weight loss, that's normal too. So anything greater than that, we will actually look into. So the first week, 10% of its weight loss is normal. Birth weight. Of course, we want to keep them warm. Feedings are usually, right now, we want to say demand feedings. We can do bottle or we can do breast. And bottle feeding, if the mom wants to do that, just remember the max he can have is about, we say 30 mils is about an ounce. So usually the max formula he can have is typically 2 to 3 ounces. The baby's stomach typically is the size of a walnut and it only holds up to 3 ounces. And that's all usually the mom should give the baby, the newborn baby. Now, if the mom does breastfeed her baby, which we have here, we usually say that he should have breastfed at least 10 to 20 minutes on each breast. So we want to make sure she empties each breast on a regular basis. And if you notice here, breastfeeding is usually more often than bottle feeding because the breastfed baby usually is more hungrier more often. Normal voiding, you want to remember, is usually the max kidneys start going about 6 to 10 wet diapers every 24 hours. That's the main thing you need to know. Stools usually go from meconium. It's that sticky, tarry, pasty looking stool, which is digested amniotic fluid, to transitional stools, which you hear about, and you can teach that to parents, to yellow stools from usually the 4th day on. If the mom asks you about breastfed stools, I tell students to tell the moms it looks like small curd cottage cheese mixed up with some mustard. So yellow, small curd cottage cheese. And that's normal. Sleep is a lot. Babies sleep 16 to 20 hours every 24 hours or 17 hours usually a day. That's normal. Cord care, we do not put alcohol on it anymore, as you learned from your protocols. And so what we do is we make sure it looks dry and it does not look infected. If it dries off, we'll just tell parents the cord usually dries off in 7 to 10 days. And if it looks dried during our hospital time there, you can take off the clamp. Only if it's dry, so no clamp. Circumcised babies, for boys, we tell students, moms and dads, never retract the foreskin if he's uncircumcised when you bathe. If he does have a circumcision, make sure it looks healing. It doesn't look infected. And the most important thing you want to make sure priority-wise is that he's voiding. And that's the most important thing, that make sure the diapers are wet. In terms of bleeding and infection, that will occur over time and that's not good. But the immediate need is that you have to make sure post-circumcision that he is voiding. That's what you want to tell mom and dad. The babies, remember in your assessment lecture, he goes from acrocyanosis, which is those blue hands and blue feet, to pink. And at this point in time, he will peak usually on the 3rd day. If he's going to get yellow, remember no yellow babies, no green babies in the labor table, but he will, if he's yellow, it will peak on the 3rd day of life. And you want to remember this, at the most 12 milligrams per deciliter. And that is the most he will peak. It should go down from that point on. And we're going to talk a little bit about physiological jaundice later. and that's the next few slides on. But just remember this right here. Normal, what we call physiological jaundice, peaks on the third day of life at 12 milligrams per deciliter. Lastly, labs, which is normal, he'll get a normal newborn screen, which screens the baby's blood for inbred metabolic diseases such as sickle cell anemia, galactosemia, PKU. This is done for all babies, a newborn screen. All these others are not normal. We'll do AccuChecks for glucose, not common, urine toxicology to rule out toxicology screen, which we use, say, for drugs, and CBC to rule out sepsis. That is not normal. So if your babies that you take care of are getting any of these, we test, we'll say that's out of the realm of normal. Okay, then lastly, the meds would typically and always will be, he'll get erythromycin in his eyes in the labor and delivery, and you might give a vitamin K shot in his thigh for clotting because he does have a sterile gut, and vitamin K is manufactured in the gut by his normal flora when he starts eating. Normal flora is produced when he starts eating. So he needs that vitamin K because he does not have that normal flora. He hasn't started eating to start clotting. Sometimes they'll get what we call a hepatitis B immunoglobulin shot, and that's when the mom, as only PRN, only when the mom is hepatitis B positive. That's only PRN. All babies get hepatitis B vaccine. So don't mix up the two. Hepatitis B vaccine, all babies, and babies whose mom is Hep B positive only get hepatitis B immunoglobulin. And lastly, follow-up care. He will be seen by the doc, always routinely 2-day check and a 2-week check. And that is all. Be sure to read your book, and this will tell you the storyline. Okay, talk to you later.